So good morning. It's a pleasure to be here. It's actually pretty amazing to stand here for, I don't know, almost 16 years, I guess, and see many of the faces that we have grown up with as we have been working to understand the health effects in the community that was near the World Trade Center. And so today, I have a very short period of time, and I'm tasked with telling you a lot of information. So I'm going to try to tell it as a bit of a story and put it in context, because again, this is a very diverse audience, and I want it to be clear. So I'm the medical director of the World Trade Center Environmental Health Center for the survivors and community members, and my background, as you've heard, is really I began as an asthma doctor. Asthma and environmental issues were my interest, and I've been at NYU and at Bellevue and at Health and Hospitals for many, many, many years, and I'm now a professor there. And what I would like to do is sort of start by giving you some definitions so that we're all talking the same vocabulary. And the definitions I want to give you are really, when we're talking about the respiratory system, we really think about it as one unit, but we break it up into upper and lower. The upper being your sinuses, nasal passages, and vocal cords, and the lower being your bronchi, the tubes in your lung that branch into many, many, many tubes and end up in small airways and in alveoli where you do gas exchange for oxygen and carbon dioxide. And it's important to understand that because that's how we talk about respiratory disease or respiratory illness in the population that was exposed to World Trade Center dust and fumes, whether it's a responder population or a community population. And when we begin to understand what's happened to that airways, we start with really the first thing, which is symptoms. And symptoms are how somebody feels. They're not a diagnosis. Upper airway symptoms are postnasal drip, fullness in the face, facial pain, cough. Lower airway symptoms are cough, shortness of breath, chest tightness, wheezing. And what you notice from this list is that there's overlap, that you can have symptoms that are upper airway that are also symptoms that are lower airway. And that a symptom really only tells you a problem. It doesn't tell you a disease. It tells you that there's something going on that you have to figure out. So how do we figure that out? And that's not so easy, and that's where the role of research comes in, and that's where understanding disease mechanisms come in. We do physical exams, we do questionnaires, and we also do tests. And we do a lot of tests. And we ask people who are coming into our programs to do a lot of tests. And those tests include many, but one of the first ones we always do is something called spirometry, where we measure lung function. And when we're doing that, that gives us a lot of information, but there are a couple of, actually 3 main things it gives us. One is how much air you can blow out. That's very important. The second is how fast can you blow that air out? Because you should be able to blow out almost all your vital capacity. That's vital because it's vital for your life. How much air you can blow out. You should be able to blow most of that out in 1 second. And if you can't, it means that there's an obstruction in there and that may be something that is blocking that airflow. And the good thing about spirometry for research is that it's used a lot. We have standard values. It's relatively easy to do. It's non-invasive. But the bad thing is that the normal values are epidemiologic. They may not pertain to you as an individual. Often we do it at one time point, so you don't know where you're starting from or coming or going to. And also it tells you mostly large airway function. It doesn't always tell you what's going on in those smaller airways. Also, it tells you a single point in time. So for example, in a disease like asthma, which is variable, it doesn't tell, you may not catch the abnormalities at the time that you're doing spirometry. So spirometry, which is our standard that we start with, is enormously helpful, but it doesn't tell us a whole story. So other studies you're going to hear about today that we can do are studies, for example, looking at twitchiness of the lungs. And we do that with what's called a methacholine challenge test. We take a chemical, we ask you to breathe it in, we measure your lung function, and that tells us how sensitive your airways are to external exposures, to other chemicals, for example, or just other exposures in the air. So when we started our studies, we first had to understand what individuals, and I'm speaking here of community members, but clearly this pertains to others, had been exposed to, and how to describe the exposure and how to link that exposure to symptoms and lung function. And although we never developed a perfect way to describe exposure in the community members, we've known now through studies we did with New York State Department of Health and then subsequently with the New York City Department of Health that we can think about exposures to the community members as acute exposures, those that occurred on 9/11, as well as chronic exposures, those that occurred in response to the resuspended dust and from the fumes from the fires that burned. And we now know that, in fact, through these studies, that we can associate exposure with symptoms. So that gives us a dose response or an exposure response. And that's critical when we're talking about environmental health and understanding the impact of an environmental exposure. It's sort of the first thing you need to be able to do. So then the question was, what was the disease? And early on, we got clues from this from the fire department, who described, in fact, airway hyperresponsiveness or twitchiness in the firefighters. And this made sense because as we began to understand what was in that dust, we knew that it was caustic, that it had a pH of 11, and that was going to, in fact, cause a burn. But there was something more to understand about that dust. And we knew that there were about 1.2 million tons of material that were deposited throughout Lower Manhattan and in Brooklyn. But for pulmonologists, you have to understand what is that dust made out of and also what's the size of that dust or the particles, because size is important because it tells you where it's going to impact in the upper and the lower airways. And our dogma had always been that a particle that was larger than 5 micrometers was not going to get down into the deep airways and couldn't therefore do damage, but might in fact do more damage to the upper airways. But we know that in fact a lot of the particles were bigger than that. They were smaller. And so what we understood was that some of that was going to get past the normal protective mechanism, the mucociliary escalator, which would protect your lungs, and might in fact get into the small airways. But we weren't sure how to look at that. But we got clues that in fact some of these particles were getting deep into the lung. The first clue was from a firefighter who was admitted to Bellevue Hospital, got his lungs washed out, and we identified particles that were in fact large, deep in his lungs, and this was published. This manuscript was published. We got additional clues from work done again in the firefighters by a woman aptly called Fireman, who many years later showed that sputum had particles. And we got clues from the responder when we from the survivor group, when we did biopsies of some of these people and looked in the lungs themselves and saw particles within the lungs itself. But how could we look at this in a larger population and measure this? So when we began studying community members, we did spirometry. We looked at how much air you could blow out, how fast, and many people had symptoms but had normal spirometry. So we put in place another test that we didn't fully understand called force oscillation, and this test was a non-invasive test, and it was pretty easy to do. You just had to breathe regularly and hold your cheeks. And what this technique did was to measure how airflow is distributed in the lungs. And when there's disease, the airflow is no longer uniformly distributed. And so if there was disease in the small airways, we could detect abnormal measurements. So we did this routinely in our population, and what we found was, in fact, there were lots of abnormalities, but we didn't have normals. So we worked with the Department of Health, with the registry, and we did a huge study, and we were able to show that, in fact, we could detect abnormalities associated with symptoms in people who had normal spirometry, suggesting that many of these people had small as well as large airway abnormalities. I'm told I have to wrap up, so I will move pretty quickly. But we now know that injury can be varied. We know that it doesn't depend on, that it depends not only on the size, on the components, but also on individual susceptibility. We also know that the damage can be heterogeneous, that it might present as asthma in one person and as a different disease in another person. And the question now, 16 years later, is what's happened to individuals who have these persistent symptoms? And the answer is varied. When we measured spirometry over time, we in fact saw improvement. In fact, people seem to be getting better in their large airway lung function. We haven't finalized our analysis of the small airways. We looked at causes and we looked at components of inflammation, and we showed that in fact there's a variety of types of inflammation that we can see in our population. Not surprising if you understand the asthma literature, but we showed that in fact some people had eosinophils, a type of inflammation that was associated with some of their symptoms. Other people had elevation in different types of systemic inflammation that was associated with small airway disease. And then most recently, with funding from the Centers for Disease Control, we've asked a number of people to come in. We have put them on high-dose medication for asthma. We have asked, did their symptoms improve or stay improved? And in fact, what we found is almost 80 people participated in this pretty intensive study. And what we have found is that, in fact, despite being on all these medications, some of them still had symptoms, lower respiratory symptoms. So we put these people through a battery of tests, very detailed. We did extensive lung function testing. We looked for airway hyperresponsiveness. We did a vocal cord evaluation. And the data is still not published and not fully analyzed, and we're still looking at it. But what it's beginning to suggest is that many of these people still have persistent twitchiness in their airways, twitchiness in their vocal cords, and also some abnormalities in their small airways. And this is very important for us because as we talk about going in the future, this helps us figure out how do we need to now manage these individuals, what are the medical approaches that we can do, how do we target the treatments that we're going to need to do, and also tells us that there's more to learn and we need to think about how else to approach many of you who still have symptoms, although as our data is also showing, many people are beginning to improve and have resolved their symptoms as well. So I hope I did that in a short time. Thank you very much. And